So welcome to the Alpha Sigma session. This is the industry-sponsored ESHRE Congress session, and it is on the environmental and COVID effects on male fertility. And we will talk about the role of the carnitines and micronutrients. And we are very pleased to have very distinguished speakers with us this morning. And we will start with Dr. Ghulam Bahadur from London. He's the consultant clinical andrologist and lab director at the Hospital Foundation Trust, and a long-time researcher in the field. So, Ghulam, I leave the presentation to you now.
Dear colleagues, thank you very much for inviting me to talk to you. There's no conflict of interest. The title of my talk is on male factor and COVID. The question that is being asked is it possible to counteract the COVID effects on male fertility? In order to know this, we need to try and examine what has happened with COVID infection in male fertility. We look at the effect of infection, possibly vaccination, what the immune response, and the increased white blood cells, the temperature changes, the fever that is associated with it, stress, oxidative stress, and free radicals, the genetic damage and alterations, recovery phase. And what happens after the infection, increase in sperm cell death, inflammation, and oxidative stress. Is there long-term damage to male fertility? We need to look at damage to the important parts of the testes, where sperm production occurs. With COVID, there's testis damage, not just in testes, but a peripheral region causing oxygen deprivation. There's disruption to testosterone and sex hormones. There's sexual health, mental health, and we need to look at other viruses alongside, like mumps, what happened, and whether there's feasibility to preserve sperm and how you're going to manage that. In terms of improving sperm quality after COVID infection, we usually look at lifestyle stress, dietary issues, and where possible to get the right supplements. Now, every child, every person in this world will now be aware of what the COVID virus looks like. It's an mRNA virus. For the virus to infect, it needs ACE2 receptor site and the the transmembrane serine protease site here. Once both it infects, it takes over the host machinery to create many virions of itself here. It's a respiratory virus, so that's what and what happens is that once infection occurs, you're going to have T-cell response, and you have your immunological changes taking place. But what is very unusual about COVID is that there is a huge cytokine storm, which actually prevents the interferon response here. So if you look at the distribution, your first line of attack is there, followed by the brain, and then whatever else, it permeates to various parts of the organs here. So when we're looking at the brain, when you look at spermatogenesis, that's our hypothalamic pituitary axis. So the first line of disturbance is there'll be impaired LH-FSH level that will disrupt the spermatogenesis here. If we look at the mechanism by which the infection occurs here, once infection occurs, there's going to be inflammation. There's psychological stress, and that will, then on the other side, you'll have in fact orchitis, and going through latex cell, you're going to have alteration in the testosterone level, which will all dovetail into really depleted spermatogenesis and sperm abnormalities. On this side, with oxidative stress, you're going to have DNA fragmentation and the like here. Now, to borrow the Estes Agrawal picture, very nicely done, but just we're going to add on to systemic pathology is the COVID infection now. And on the environmental side, we're now going to add the COVID stress and the mental stress. And believe you me, this transgenerational stress epigenetics is a very important factor here. And this we have a measure of through a very recent paper on the C-reactive protein, which is associated with depression, and very oddly, depression does lead to inflammation here. There are three areas that we're going to look at the mechanism of spermatogenesis. You will have depletion in the level of spermatogenesis, but when it comes to Sertoli cell, you'll get breakage of the blood testis barrier, and you'll have anti-sperm antibodies. And when you look at the Leydig cell area, you're going to have hypogonadism, leading overall to male infertility here. And if we look at the cells that are relevant to us in male factor fertility, you can see ACE2 is expressed in virtually all of them here. And here's a picture of how various patients and the histology of the testes. And what you can see is that these are all infected regions where the ACE2 and the TMP-RSS expression is significantly higher than the controls here. Here we see the picture of the dreaded COVID virion, and this is quite important confirmation for our field. And with the level of ACE2 level of expression, you also have much significant levels of spermatogenesis here. In the next few slides, I'm going to go through very quickly because, again, these are histology slides. It is necessary to emphasize that to show that there is seminiferous tubule injury here, and that there are prominent CD8 positive T cell infiltrates here. There's also significant levels of IgG in the seminiferous tubule here, reflecting the infection, and the inflammation markers are quite significantly higher than in controls. This picture also very importantly tells you how damaged the testes is after, and one of the other knock-on effect is the level of apoptosis that goes on in the testes. Now, this is the first longitudinal study in multiple for male factor fertility against the COVID infection. The seminal ACE2's activity markers show the inflammation and oxidative stress, apoptotic variables, semen quality parameters, and these were evaluated 10 days at 10-day interval for up to 60 days. And it shows that the reveals very significant level of ACE2 enzymic activity. The interleukin, the inflammation markers are significantly increased. The ROS and the kind of caspase activity, that too is increased, as is the DNA. What we also find in this paper is that the volume motility, all parameters of sperm are significantly deteriorated. And in terms of the inflammation markers against COVID, you can see they're all significant here. And this is a very, very good study, I have to add. There are many, many studies that have dismissed really all of them. Well, apart from another one. The oxidative stress markers, again, even after 60 days, they prevail. And I think this is quite important for us to recognize, as is the apoptotic variables right across, right up to 60 days after COVID infection here. In fact, when we look at the semen parameters against the ACE2 activities, the volume, the progressive motility, the morphology, the concentration, and the numbers, total number of sperm, they're all significantly reduced. In another paper, what it highlights is the presence of leukocytes in quite high numbers. Now we have to draw parallels, and as to what we know with other scenarios. And in paternal age, there's increased level of miscarriage. That's your contributor when this is sperm before COVID, this is sperm after COVID, and the kind of embryos, you can see the very poor quality embryos being produced. And again, what we know from what DNA fragmentation does is that whilst this predicts the outcomes, but again, there's a kind of damage that we're looking at in COVID patients. The maternal and neonatal morbidity and mortality in pregnancy is very significant for where there is symptomatic diagnosis against asymptomatic diagnosis. And this is becoming more and more important in this field here. And the next 3 slides, I'm not going to go into the detail because there's a lot of information to absorb, but suffice to say that the preterm birth and pregnancy loss are significant, as is spontaneous and therapeutic abortions, and the preterm birth and pregnancy loss is significant. And even in today's paper, Infertility and Sterility, the stillbirths and miscarriages very much increase after infection. Now, I've shown you different types of tissues. Now, we need to be careful when we talk about measurements, because types of tissue and the disease severity will have will give you different level of measurements. And those who have been very severely affected, like for instance those who were hospitalized with COVID, will have a much greater antibody response to those who haven't. And between men and women too, there are differences. In fact, it seems that women appear to be more protected, and we can interpret it both ways. So there may be an issue of alteration of testosterone or estrogen effect here. Now, coming back to what I wanted to talk to you about is that clearly there's a lot of evidence of oxidative stress here, and for that there's DNA damage, and we need to learn how to. There's sufficient data now that tells us how to repair this in terms of male fertility. And so we looked in the Cochrane review, and in fact, in terms of certainly between where antioxidants were used against the control, it was certainly favorable antioxidants when it came to live birth per couple. And the live birth and pregnancy, again, this was significantly better, favorable for where antioxidants were used. As is the DNA fragmentation, it was again favorable where antioxidants were used. Of course, we can argue about the weight and quality of this, but this is evidence, you know. But the good thing is that they're more low risk of bias than the high risk of bias here. And so the authors conclude that antioxidant supplementation in subfertile may well improve live birth and for couples undergoing ART. In the more recent Cochrane review, again, the picture gets even better because the low risk bias seems to get the more of it and less of that. But when we talk about scientific rigor, we want to look at the strength of evidence and some in the same breath. And although it says weak evidence in the Cochrane, but hang on, all these evidence are no different from a lot of the practices that go on in IVF currently. And the other area that I want to deal with is vaccination. Is that there are 3 major ways of vaccination: protein-based, viral vector, and messenger. Messenger has never been used in humans before, and it does worry me at the point of fertilization, what the implication of this is. So to conclude, dear colleagues, is it possible to counteract the COVID effects on male fertility? And the answer is yes. We have a lot of information here that I've shown you, and they are just, but in terms of actual direct detailed study, this was not possible because we're focusing on life-saving issues, not the pandemic, not the quality of sperm here. Sperm and sperm damage does exist, and although there's limited data, what I've shown you is real quality data here now. SARS-CoV confirmed in testes. This is vital, and once it's there, the issue is that sexual transmission is permissible, is possible. The evidence of sperm damage which manifests in, again, limited data, and I've shown you a good quality picture here. And the area of stillbirths and miscarriage, this is seriously increasing now. And I think perhaps we have very few handles, and it seems that the only handle we have here in terms of correcting anything is getting that DNA repaired and suppressing the level of oxidative damage. I think, dear colleagues, we have just begun. Thank you very much for listening.